All right, it looks like it's 8 o'clock, so we're going to get started. And if people come in a couple of minutes, then that's totally fine as well. But yeah, so hi, my name is Olivia. I am a third year medical student at the University of Iowa Carver College of Medicine. I was here last week. We talked about thyroid cancer. And so, welcome back to any of you who were joining us last week, and welcome to anyone who is here for the first time today. We have a topic that was requested a few months ago, which is a pediatrics topic on neonatal physiology. So we're going to go through a simulated case, just like always, and that will include a physical exam and differential diagnosis. And then we'll kind of run through the assessment and plan and do a lesson on a combination today of physiology and pathology. So if you're having any trouble with the links that I put, or if you're not able to see them, please drop something in the chat or unmute yourself to let me know. I really encourage you all to participate and speak up and share your thoughts and questions with the group in whatever way you are most comfortable with. And then at the end, if you want that certificate of completion, then the quiz is there as well. So yeah, if there's any questions at any point, or if you want to go back or slow down, please feel free to let me know. I'll give you guys just a quick second to pull up your SOAP note if you don't have it already. We have a 26-year-old G1 P0 female at 31 weeks and 4 days. So if you were here for my presentation back a couple months ago about preeclampsia, we went into a little bit more detail with this G1 notation. Essentially, what this is saying is just that this is her first pregnancy. She doesn't have any prior pregnancies or deliveries before this. And the normal length of gestation is 40 weeks. So she's, 31 weeks and 4 days. This is about 3/4 of the way through, but this is still concerning for preterm labor. So it sounds like she came in 2 days ago with signs of her water breaking or rupture of membranes. And when it's before 34 weeks, I believe, that's when we call it preterm premature rupture of membranes, or PPROM. So a lot of strange notation at the beginning. I promise it's not going to be like this for the rest of the thing, but just some jargon that you might come across in the future. And for people who are interested in OBGYN, this is, again, something that is a little bit more in that. So if you're interested, then you can go back to the YouTube recording for preeclampsia and learn more about this nomenclature. So in her pregnancy, otherwise, besides having this potential water breaking and signs of labor, everything else has gone pretty well. Her only complication has been gestational diabetes. And she's received all prenatal care. So there's nothing that we would have expected to come up or could have done differently to prevent this. And despite our best efforts, she is now in active labor and is pushing for a delivery to be happening soon. So what are some things that, if you're the pediatrician who is attending this labor and we have this preemie, what are some things that you would be most worried about or on the top of your to-do list when the baby is born? And these can be like really specific things or really just general things, like things that you'd want to just be observing for. Apgars, love that. ABCs, both very important initial assessments to make after delivery. So Jonathan and Seema both nailed what I was looking for. Any other things like specific to a baby being born, like they've got an umbilical cord. So like we'd want to, clamp that off and cut the cord so we can get baby detached from mom and be able to move around and do that. This is a little bit of a unique situation because we have a patient that's the mother, and then we also have a new baby patient as well. So they have a saying where if you, during a delivery, want to go back and help the mom, then you're probably more of like a surgeon or OBGYN person. If you want to follow where the baby goes, then you have more of the qualities of a pediatrician. I don't know if that's true. It's just something that I've heard. And delivering the placenta, again, very good. That is typically done by the obstetrician and not the pediatrics, but that's something that would definitely happen within usually 30 minutes of delivery. Ashley says that lungs will not be fully developed, and that is an excellent point, and it's going to end up being one of the focal points of this presentation. So that's a great thing to predict as well. So it's a girl, yay, congrats, mom. Mom is being taken care of by the OB team. And some of the first things we do, like we said, is clamp and cut the umbilical cord. So it's important to remember that this cord is not just some connective tissue that is connecting baby to mom, but it's 2 arteries and 1 vein. So a live cluster of vessels that is actively pumping blood in both directions. So it's very important to clamp off at both ends. So one side on baby's side, one side on mom's side, and then cut in the middle so that we don't have blood, coming out from either patient here. That can cause, a lot of blood loss and complications if you don't clamp on both sides. So got to remember to clamp it. Next thing, baby's going to get moved over to the warmer. That's kind of what this picture is showing over here. It helps keep their temperature regulated, and it also has all of the things to measure their vitals and get their weight and that sort of stuff. Suctioning the newborn. I think there's a little tiny suction bottle on the tray up here. So that's another great thing to do. It'll help kind of clear out their secretions of the nose and mouth that can help them to breathe easier. And so that's another thing that we can do as well. And then people had mentioned Apgars and Vitals. So again, those are the quickest and most, I would say, important things to measure right after delivery that help us to determine what kind of state baby is in. So ABCs stands for airway, breathing, and circulation. Those are like the 3 most important part of any sort of assessment or resuscitation of any patient in any circumstance. Sometimes it's not always done in like such an obvious way, because if you're sitting up and talking to someone, you can just kind of assume that they're, all taken care of. But in trauma situations, in like critical care situations, things like this, you'd always want to, do a more intensive assessment of their ABCs. And then we're going to talk about the Apgar on the next slide. And then because this is a preemie and we're expecting them to have some complications, we want to transport them to the NICU as soon as possible. So we have a more dedicated staff and better resources to help if there was any potential need for things like intubating or starting lines and stuff like that. So that's kind of the very rapid sequence of events. It seems very like laid out right here on this slide, but in real life, it happens so fast. These doctors and nurses and other healthcare team members are extremely good at what they do and have it down to a science. But for a student or someone observing, it seems like, oh my gosh, there's just so much happening. So I guess I lied about the Apgar. It'll be the one after this. But like I mentioned, with the umbilical cord, it has 2 arteries and a vein. So the arteries that are going from mom to baby are going to supply the baby with oxygen and nutrients that are pretty much, the baby's like, I don't know, way of eating and lungs, like functionally their lungs while they're in the womb, because there's no oxygen for them to breathe while they're in the uterus. You're also getting some immunity through IgG and some hormones as well that are passed from mom to baby. And then the baby essentially will put off things like carbon dioxide that they're not breathing out as a gas. They're returning in the blood through the umbilical vein so that mom can breathe out the carbon dioxide, and then other waste products as well. So while babies can urinate in the womb, and that's what essentially makes up amniotic fluid, it's a very dilute urine, and all of their like toxic waste products are excreted through their umbilical vein. So just a little quick recap about those. And now for the Afghar score, I think maybe it was Ashley or Jonathan. It was Jonathan who said that we should do Apgar. So this is a assessment that's done with all newborns at 1 and 5 minutes to assess for how well they're adapting from a cardiovascular standpoint to delivery. So The acronym part of it, I think, can sometimes be a little bit confusing because things like grimace, you would expect it to be like associated with their cry, and that's actually respiration. But I don't know, they just call it Apgar, and then you're basically evaluating how they look and what their vitals are. So for appearance, you're basically looking at their color. Are they nice and pink? Are they really blue and pale all over? Or are they somewhere in the middle where they have like a mostly pink, like head and trunk, but maybe their hands and feet are blue, and that's called acrocyanosis. So that's a very, very common thing for even healthy babies to have acrocyanosis. It's just kind of a thing that happens after delivery because they do have to go through a period of less oxygen when they're coming out. P is for pulse. So we're looking for anything over 100 beats per minute. Vitals differ dramatically between adults and newborns. So a normal heart rate for a baby is anywhere from 100 to 160. In an adult, that is definitely too high for just a resting heart rate. And so you'll notice when we go through the vitals later on that they'll also look a little bit wonky, but rest assured that babies just have different vitals. If they are less than 100 beats per minute, then that's 1 point. And if they don't have a pulse at all, that's obviously very bad. For grimace, we're looking for their response to stimulation. So a lot of the times after babies are born, you'll see especially the nurses kind of like really rubbing on them and like trying to irritate them almost. And that gets them to flex their extremities and to stimulate their crying and things like that. So the more responsive you are to the stimulation, the better score you'll get. For activity or muscle tone, usually babies are very flexed up and they have their legs almost all the way up by their ears, and that's very normal. In fact, if they were more floppy and just kind of having everything laid out, that's a worse sign. So we want them to be nice and flexed and to have the ability to move around. And then for respiration, we pretty much just measure this by looking at their cry. So when babies cry in a hospital, usually someone will joke like, oh, they've got great lungs. So if they have a good vigorous cry, then that means that they're breathing well. And if they're not crying, or if they're making sort of maybe like some irregular gasping sounds, then that's again a sign that they could have some respiratory distress. So that's an overview of the Apgar. Our patient had Apgar scores of 6 and 7 at 1 and 5 minutes. So that's, not like a perfect score, obviously, and it's definitely warrants her staying in the NICU and making sure that things are monitored to if things happen to regress or get worse, then we can intervene. And this is just a picture of that acrocyanosis as well. You can see the feet are kind of this purpley color, but then the legs and the stomach look nice and pink. Okay, so on physical exam, the vitals here, again, I said they're going to look a little weird in an adult. If you had an 85/52 blood pressure, you'd be like, oh my gosh, they're in shock or they're bleeding somewhere. This is actually a totally normal blood pressure for a newborn. Heart rate of 144 is perfect. Again, it's somewhere between 100 and 160. Respiratory rate, it's a little high. In fact, newborns can have a respiratory rate between like 30 to 50 or 30 to 60 breaths per minute, which is way high for an adult. But in someone that's just been born, and especially if they have underdeveloped lungs, then having this high of a respiratory rate is not unexpected. Temperature 36.4, so maybe a little bit on the low side compared to 37, which is our normal physiologic temperature. And babies tend to lose heat very easily. So that's why, again, it's important to keep them under the warmer and to get them wrapped in blankets as soon as possible. And then oxygen saturation of 96%. In someone who's born at 31 weeks and we're worried about their lungs not being fully developed, then that's something that we're going to want to watch closely to see if it stays. Usually above like 92 is the cutoff for hypoxia that we want to avoid. But right now, all of these vitals are within normal limits and they look okay. Baby's weight was 1790 grams, or around 3.9 pounds, and a length of 28 centimeters, or about 11 inches. So it's a little tiny baby. The physical exam that I have listed below, if you'd like to read it or copy it for your objective section of the note, then that's totally fine. I just wanted to emphasize the important, or like the abnormal parts, which is mostly their lungs. So on auscultation of the lungs, we hear mild crackles bilaterally, and also are observing that they're using accessory muscles of respiration. They have subcostal retractions, nasal flaring, and grunting. So those 4 things that I just listed are classically signs of respiratory distress in a newborn. Those muscles of accessory muscles of respiration are because that helps to expand the lungs when you can't do that with just your diaphragm. And then the retractions and the nasal flaring and grunting are just sort of like other physiologic responses to trying to get more oxygen and more airflow into the lungs. For the HEENT, or the head and neck exam, I also wanted to see if anyone knew what the anterior fontanelle means. Like what structure are we referring to? Madeline said soft spot. So yeah, right on. Babies have a little soft spot, or like a part of their skull that hasn't fused together quite yet. And so that spot is, a very sensitive and vulnerable place that we want to avoid having any injury to. And I think usually by like, I actually don't know off the top of my head when it closes, but obviously your skull will eventually, the bones will fuse and you won't have that anymore. So, but in babies, we can feel that on their head and neck exam. Okay, we've gone through a lot of information so far. Does anyone have any questions or need to go back to anything? Are we going at a good pace as well? Am I going too fast for you guys at all? Okay, we'll keep going. All right, so baby's still having some trouble breathing. What are some things that we think could be going on, or some things that we can do to help? It doesn't have to be like a specific diagnosis. Harley said give oxygen. That's a great idea. Suction as well. We can continue to do suction and see if there's any more of that like mucus that can come out. Oxygen mask. Yeah, usually we would either do like the nasal prongs, or if they need like a CPAP or BiPAP type, like forced air into the nose or mouth, then that can be done through a mask. So those are good ideas. Does anyone, if this is, I know, a challenging question, does anyone have any ideas of what could be causing the trouble breathing? And it could just be, there's the like underdeveloped lungs as well. Organs not fully developed, fluid in the lungs. Yeah, those are great ideas. So I just wanted to run through 3 things. Just there's more than 3 total, but 3 things for this case that could cause respiratory problems in a newborn. So the first one is transient tachypnea of the newborn. Tachypnea means a fast breathing rate. So like we saw in the vitals, that maybe the breathing rate was a little bit elevated. This is the most common respiratory condition out of any age, any, length of gestation that the baby was born at. And it is also the most mild respiratory condition. So essentially, it's just that amniotic fluid that is filling the baby's lungs and airway before birth. It takes a longer time for that to clear. And so they do almost have like a pneumonia type picture because of the fluid that's still in their lungs. It is the most mild, and it will almost always just resolve on its own within a day or a couple of days. And we don't have to do anything except just supportive care for that. So that's TTN. The second one is neonatal respiratory distress syndrome. And this is something that I would say is one of the highest things on our differential for this patient because she was born below 32 weeks. And this is caused by low levels of something called pulmonary surfactant. So surfactant, we're going to talk about a little bit more later, but in a nutshell, it's a substance that's produced by the lungs to help keep the little air sacs, the alveoli, at the distal end of the lungs open. And if you can't have them stay open, then you get this partial collapse of the air sacs called atelectasis. And this is the most common respiratory condition seen in infants that are born at 28 to 34 weeks, which is exactly where our patient falls into. And then one of the more serious and rare types of respiratory problems in a newborn is pulmonary hypoplasia or pulmonary dysplasia. And this is more commonly seen in extremely preterm infants, so like micropreemies. And this is where the lungs are so poorly developed that they structurally cannot function the way that they're supposed to. Like you just don't have the anatomy quite yet to be able to facilitate gas diffusion and things like that. And there are some other congenital malformations that are associated with this. So I'll show a couple of scans later on that we can see like why that might happen. So the one right now that I'm thinking is the most likely, is the neonatal respiratory distress syndrome, just based on gestational age and the symptoms that she's having. So if we did a chest x-ray and compare it with a normal, the normal side on the left, we see those nice dark lungs and the little kind of streaks that look like they're maybe fanning out by the heart. Those are the vessels of the lungs that are supposed to be there, and they're normal and they're allow that gas diffusion to occur. And contrast that with on the right in a patient with respiratory distress syndrome, their lungs look very cloudy and white. And that is kind of referred to as ground glass opacities. And that's a non-specific description of what's happening here, but it basically is just indicating that there's that process of atelectasis that's happening in the alveoli of the lungs. So you get this sort of whiteout picture bilaterally. And that's pretty much the only finding on chest x-ray. There's other things that we can evaluate clinically on physical exam and such, and use that epidemiological information of like gestational ages that are like most associated with those differential things that we talked about before. But on chest x-ray, this is the main thing that we're looking for. I think I just got a notification that someone's hand is raised. If you'd like to ask a question, please feel free. And if not, then you can type it in the chat, or sometimes I know that those things happen on accident, but if you have any questions, then just feel free to unmute yourself at any time. Okay, so moving on to our assessment and plan. We have a summary statement here, kind of with all of the information that we've looked at so far that explains kind of our line of thinking, and this is the assessment portion. So we have a 1-hour-old female who's born via spontaneous vaginal delivery at 31 weeks and 6 days following PPROM, or that preterm premature rupture of membranes. Pregnancy was complicated by gestational diabetes. The mother received antenatal corticosteroids. I'll explain that a little bit more later. And the infant's vitals have been within normal limits. The exam is significant for signs of respiratory distress. Concern for neonatal respiratory distress syndrome, secondary to surfactant deficiency, was confirmed with a chest x-ray, and the patient is currently stable. So again, a lot of information there, but it's basically just summarizing the background of the case, like how old is this child, how far along in the pregnancy were they, and how are they doing right now? What are we thinking might be going on, and how have we worked it up to try to come to that conclusion? So for our plan, like many of you guessed, We are going to give supplemental oxygen. We're going to try to keep it between 21 to 30% oxygen and consider intubation if things are not improving. We can also administer surfactant and do kind of like a delivery through the airway, and have that kind of supplement what would have otherwise been there if the baby had been allowed to develop further along before birth. And then because the mom had gestational diabetes, we also want to monitor baby's blood glucose levels for hypoglycemia. It might seem a little bit counterintuitive that if the mom had just diabetes, which is high blood sugar, that the baby would have low blood sugar, but it's kind of like a withdrawal per se of if they're used to having high blood sugar in the placental circulation for so long, when they don't get that anymore, their bodies haven't adapted to not getting it. And so they can have like a refractory low blood sugar. And then lastly, just for any patient with respiratory problems, it's very common to just give empiric antibiotics until we rule out that it's neonatal sepsis or some sort of infectious process causing this respiratory distress picture. So that's our plan. Do you guys have any questions at this point? And how are we doing? Are we feeling overwhelmed at all? Or is this still like a good level of information and good pace? Okay, excellent. Thank you guys. Diana, was there a specific slide that you wanted to see? The previous one, yes. I'll leave the assessment and plan up for a couple more seconds in case you guys needed to put any of this in your note. And at the end too, if there's anything that we missed, I can put the link to this presentation in the chat for you to use to fill in any gaps of the note. What would determine whether a preterm baby would be born vaginally versus C-section? That's an excellent question. And in fact, that's one that I was even a little bit struggling with when I was writing this case. A lot of it comes down to what the preference of the mother is. A lot of moms have a specific birth experience that they envision for themselves and want to try to do things as naturally as possible. And medically, it's our job, not as much on the pediatric side, but on the OBGYN side, to try to balance the patient's wishes with what is medically safe and best for both of the patients. So of course, like if there's a really dramatic drop in heart rate in the uterus that the baby has giving signs that they're not doing well, then that would be like, okay, we got to go do C-section right now. But in this case, it looks like, you know, there was some signs of preterm labor and water broke. And there are some things that we can do to try to hold off labor for a little while, but sometimes those just don't work, and the moms progress through the stages of labor. And if they're medically safe to deliver vaginally and would prefer to do it that way, then usually that is a possibility. Does that answer your question? And in this case, I think like I have seen that babies are born around this time frame with a vaginal birth, but some of the really, really, really young ones, I think the youngest baby that I've ever seen while I did a NICU rotation was born at 21 weeks and 5 days, which is literally like half the amount of time that they're supposed to be in the uterus developing. So it was a really amazing case. And it just is kind of, again, a case by case basis. Hopefully that answers your question. Okay, let's move on. So a little bit of epidemiology about neonatal RDS specifically, or respiratory distress syndrome. So essentially the earlier you're born, the higher your risk is of developing this, because again, you don't have the developed anatomy of your lungs to facilitate what it's supposed to do. So, born between 24 to 25 weeks is 92% of those births, so virtually all of them. And then from there, it does drop, the rate drops, but by 30 to 31 weeks, it's about just over half. And then by 34 weeks, again, it drops off significantly because the cells required to produce the surfactant are at that point like mostly developed. So some risk factors for neonatal RDS is prematurity, which is I think pretty obvious. But then also 6 times more likely if the mother has diabetes, whether that's gestational diabetes or type 1 or type 2 diabetes. And I'm not totally sure on what the link is between that. So I don't know if anyone is wondering. I also am wondering. And then in male infants, again, don't really know why that link is there, and second born in a set of twins. Twins are really interesting, actually, in how they develop and their birth process and how they respond to delivery isn't always exactly the same as you would expect it to be. So this is a newborn physiology virtual rounds after all. So I just wanted to take some time to go through what types of changes you see that happen at birth. So in a lot of the papers you find, it's pretty commonly said that the neonatal period is one of the most dramatic physiologic changes that occur during all of human life. It involves changes to multiple organ systems that can either be temporary or lifelong. And also you will never have an adrenaline rush bigger than the one that you have while you're being born. So it's a lot going on. It's a cool transition from out of the womb to the real world. Starting with cardiovascular. So I have a picture here of the fetal circulation. Like we talked about before, your placenta is going to provide essentially like respiratory function, exocrine function, growth, things like that. And so the blood, rather than going like from the lung or getting oxygenated blood from the lungs, is all coming from the placenta. So you have some of these shunts that are present during gestation, but they will close and eventually just become like little ligaments later on in life. So that process begins at birth, and sometimes if they don't close fully, you can get heart murmurs or other vascular abnormalities, but that starts to close. You have a higher blood flow to your pulmonary circulation. Again, that's something that's bypassed essentially during gestation. And so when you're born and you have to actually use your lungs to get oxygen, then you want to have blood flow to your lungs. You also have a much higher heart rate and higher cardiac output at birth to try to compensate for all of these changes that are happening and all the adrenaline that's pumping through your body. And we use heart rate as kind of like the number one sign to measure how your vitals are doing. Because if your heart is pumping, then everything else is, sufficient enough to be able to support your heart pumping. So those are some cardiovascular changes that happen. Pulmonary circulation, again, is one of the biggest things that changes. So this image here is depicting the vascular resistance of the pulmonary vessels. So your heart, you from your right side of the heart, you get branching of your pulmonary arteries, and then that goes down and it basically goes all around the lungs to receive oxygen from the air that you breathe. And then it also will diffuse carbon dioxide back into the lung space to exhale and get out of your bloodstream. So that lung circulation here, when you're in the womb, is under very high resistance. And so there's very little blood flow to the lungs because they're not being used. So the mechanism is kind of like, why would you send blood there if it's not like being used for anything? And so it's under very high resistance. And then when you're born, that resistance drops significantly so that you can have higher blood flow to the lungs and to be able to participate in that gas diffusion process. Conversely, you also have a slight increase of vascular resistance in the rest of the body so that you can kind of balance your cardiac output and where it's going and be able to match what physiologically is happening in those locations. So drop in pulmonary vascular resistance so you can have higher blood flow to your lungs is the key thing that's happening here. A result of this not happening would be persistent pulmonary hypertension, and that again is not good. It's the result of if you don't have a adequate response to this increase in oxygen in your environment, then your resistance would stay high and that would cause pulmonary hypertension. So kind of the flip side of like what would happen if your cardiac shunts didn't close, you'd get a heart murmur. This would be the result of this didn't happen. From the endocrine standpoint, again, you're having a huge catecholamine surge. Catecholamines are things like adrenaline, epinephrine, norepinephrine, stuff like that. So that's going to be stimulating blood sugar increases through gluconeogenesis that happens in the liver. And it is going to increase your blood sugar, again, to get energy out to all of those organs that need it. You also have this type of fat that you're born with called brown adipose tissue. It's something that goes away as we get older. And essentially its function is to do something called non-shivering thermogenesis. So like we said before, babies tend to lose heat very easily because of the way that their body surface area is like different than adults. So something that helps them maintain their body temperature is by burning this brown adipose tissue for energy and to maintain their heat. And then another thing that can happen if your organs are underdeveloped, including the liver, is a phenomenon called neonatal jaundice, which can be normal in some circumstances. And sometimes it's really bad and like you can have too much buildup of bilirubin, but in some babies, they just have to sit under these little UV lights, or they're called Billy lights, but it's essentially UV light that helps the enzymes that are in the skin conjugate bilirubin so that it can be more easily excreted through the urine and other excretory mechanisms. So that's what this picture is showing, a little baby under the Billy lights, and just again kind of illustrating that in a lot of cases it is pretty harmless. We just monitor it to make sure it doesn't get too out of hand. Okay, and then last physiologic slide here. So while you're in the womb, there's a different type of hemoglobin called fetal hemoglobin. And I don't know if you guys have taken biochemistry, but at least when I did in undergrad, it was like we talked about the hemoglobin dissociation curves and cooperativity and stuff like that. So maybe you've had a little bit of exposure to this before, but essentially fetal hemoglobin has a higher affinity for oxygen than adult hemoglobin does, because while you're in the womb, you want to really hold on to and store that oxygen in your blood and in your tissues for as long as possible, because you'll just kind of like always be getting oxygen in through the blood. And then in adults, the adult hemoglobin has a less avid binding, or it's like less, I don't know, less strongly binding oxygen. So it unloads easier into your muscles and into your tissue. And so we see this shift on the dissociation curve of how much our oxygen is able to bind and like when it is unbound under certain pressures. I don't want you guys to worry about this graph, and the numbers are very specific. Just know that you get this shift in the hemoglobin at some point starting after you're born. Some other immunity type things, the placenta, like I said, transmits immunoglobulins through the circulation that can stay within baby's bloodstream and body for up to 4 months. So it provides some longer lasting immunity. And that's actually one of the mechanisms that we are looking at right now of moms who have gotten a COVID-19 vaccine and can transmit transplacental antibodies into their babies that will last for a couple months after birth. And then once those are gone, then you can still get antibodies through breast milk in the form of IgA. And those last not as long as the IgGs, but if you're continuously breastfeeding, then you can have like a good source of them constantly. And then the last thing is that it takes a couple of days or a couple of weeks, but eventually you will start producing vitamin K in the gut. And this vitamin is essential for a couple of different clotting factors in the blood clotting cascade. So because it takes a little bit for after birth to start producing vitamin K, we want to give a vitamin K shot to help prevent episodes of bleeding after birth. So in summary, because I know that that was a lot of information, I tried to just pick the main thing from each category. For cardiac, we start to see closure of those fetal vascular shunts. In the pulmonary, we see a rapid decrease of resistance and an increase of blood flow to the lungs. In the endocrine system, we see an increase in hepatic gluconeogenesis, and we start to see higher clearance of bilirubin. And in the blood, we start producing adult hemoglobin or hemoglobin A, and we also start producing vitamin K to help with blood clotting. I know that was a lot of information. You guys, do you have any questions, or would you like to go back to any of those slides to clarify or to revisit any of that information? We just have a really short pathology. Kayla had an excellent question. What is bilirubin? That is definitely something I should have included in this. And I don't think you missed that. I think I just didn't talk about it. So let me answer that for you. Yes, bilirubin is a byproduct of the breakdown of red blood cells. So red blood cells have something called heme in it, and it's a molecule that helps to conjugate the oxygen that's carried by the red blood cells. So when your red blood cells are exhausted and they are broken down, then the products in there of the hemoglobin and the heme are put through a pathway of breakdown that produces the byproduct called bilirubin. And normally it's cleared by the liver, but when you don't have a fully functional liver, then it can distribute itself in your tissues like your skin and your eyes and things like, and even your brain if it's high enough levels. And that's what makes you discolored with like a jaundice or like a yellowy color. So that was a very, very excellent question. And I'm sorry that I forgot to include that, but thank you for asking, because I'm sure other people were also wondering. And we went back to the summary slide. Was there anything here in the summary or in the other ones that you guys wanted to talk about a little bit more? Okay, but yes, thank you again, Kayla, for asking that question. That was a great question. Okay, so like I said before, in our differential diagnosis, we had the 3 different respiratory problems of transient tachypnea of the newborn, respiratory distress syndrome, and pulmonary hypoplasia. So I wanted to walk you guys through what the chest x-rays would look like for each of these conditions. So the first one for TTN, or transient tachypnea of the newborn, this is again the one that is the most common respiratory condition in term infants. So even ones that are born on time at 40 weeks, they can still have this. And their chest x-ray looks totally normal. It's just the clear fluid that is still taking a while to get cleared through the lungs that are blocking some of the air from being diffused across the membranes. So on their x-ray, it doesn't really look like anything is going on at all. RDS, in comparison, is going to have that same whiteout kind of appearance of the ground glass opacities. And each of those, I guess, like if you zoomed in on it, they would be like little tiny areas of consolidation, which are the air sacs at the end of the lungs that are kind of collapsed in on itself. And then lastly, I think this is a very interesting presentation here on this pulmonary hypoplasia. So there can be multiple causes of this. This is just one of them, but pulmonary hypoplasia can be associated with something called a congenital diaphragmatic hernia. And the diaphragm, which is your primary muscle of respiration that sits underneath the lungs and creates a negative pressure so that air can fill the lungs, has holes that are supposed to be there that allow your vessels like the aorta and the vena cava and your esophagus to pass through them and to enter the abdomen. Sometimes if you have a hole that's too big or that it's not supposed to be there, then you get the abdominal contents, so literally like your bowel and your stomach, can enter the chest cavity and cause compression of the lungs while they're supposed to be developing, so that you don't have full development. I just think this is really crazy. And I'm interested in doing surgery, and I love pediatrics too. So maybe that's why I get excited about this, because the only way you can fix it is with surgery. But like you can see the literal loops of bowel that are just in the chest cavity that are not supposed to be there. And then you can see on the right side, which is, if you're looking at it, it's on your left, but it's the patient's right, that the lung does not have like a nice uniform shape. It's kind of like oddly folded. And that's because, again, there's just so much that's being compressed in the chest cavity that it wasn't allowed to develop fully. So I don't know. I think that one's really interesting. And maybe you guys are thinking that I'm crazy, but that's just one cause of pulmonary hypoplasia. Again, our patient is this one that is here in the middle. So I think we're almost to the end here. I wanted to go over the pathology of respiratory distress syndrome, distress syndrome in general. So the exact type of cells that produce what we talked about before, that pulmonary surfactant, are called type 2 pneumocytes. And if you look at this figure over here, we have, the bronchial tree that starts with the trachea, that breaks into your main bronchi, and those eventually keep breaking off and breaking off and breaking off until you get to these little microscopic alveoli, or the air sacs. And that's where the actual gas diffusion happens, because they're very, very thin single cell layer of very flat cells that will help gas to diffuse back and forth between the blood vessel and the lung tissue. So most of them are type 1 pneumocytes, which are these like flat, or I guess they're kind of square here, but if you looked under a microscope, they'd be like very, very flat tissue. And then type 2 alveolar cells, which are these surfactant producing cells. And these cells are not fully developed yet. They're not present in either the level of differentiation or the quantity that's needed to produce the surfactant. And then also, just to clarify, I think I talked a little bit about this earlier, but surfactant is a lipid-rich secretion that its function to prevent this airway collapse is by reducing surface tension. And I want to emphasize that when you have like this air coming in, if you have too much surface tension when you exhale, then when all the air gets sucked out, you're just going to like collapse your alveoli on itself. So you want to make sure that it's held open, and that when you exhale, that they don't just fall back in and collapse. So these cells start to form around 30 weeks, and that is induced by a cortisol surge. So we actually give mom corticosteroids, like I mentioned in the assessment back a few slides ago. And that kind of, if they're showing signs of preterm labor, this can mimic that natural cortisol surge that would have otherwise helped promote this lung development. And if they're not showing any signs of preterm labor, then we don't give corticosteroids. This is just for moms who have signs of early labor. And when we have prematurity or premature birth, then this process is like completely interrupted, and the effect is going to be these low levels of surfactant, and that would present after birth as like alveoli collapse, or atelectasis is the official like medical name for it. So really quick, going back, the lines that are going down the spines in the second and third picture, that's a great question. And Madeline is right that they are just like lines or leads from things that are happening outside. So you got great eyes, so I'll walk you through really quick what they are. So in the second picture, if you can see where my cursor is, this is actually an endotracheal tube, or like if the baby had been intubated. And so that's going into their main like trachea. And then the line here going right down the middle of the spine and into the stomach is a feeding tube. So it can be hard to tell if it's inside or if it's outside. Contrast that with what's on the third picture over here. These ones that are kind of like going around the back and attached to like this little like sticker looking thing, that is an EKG lead or a lead of some sort. It looks like this baby does also have a feeding tube. And then the ones that are kind of down by where the belly button is, and that ends kind of up here looking like it's in the heart, that's actually an umbilical line. So you can start IVs or arterial lines going through the umbilical arteries, because they're already like one of the biggest and most accessible blood vessels to the outside world. So we can take advantage of that in a newborn, because those umbilical vessels are still open. In an adult, they're closed off and they just become like remnants of, I don't know, like a ligament or something. But in a baby, this is a great way to get vascular access. So thank you for asking, and I'm very impressed with your observation skills. Okay, do you guys have any questions about the pathology of RDS? We're almost to the end, and we're almost, to the end of our hour as well. So I don't want to like press you guys for questions that you don't have, but if you do think of any, then we can go back at the end. So very last thing I think of this presentation is this clinical management, and we kind of go over just a recap of the diagnosis and the treatment. So for neonatal respiratory distress syndrome, this is the most common in 28 to 32 weekers, and we see these ground glass opacities on the chest x-ray. And the treatment for that, which we kind of went over in the plan, we try to prevent it by giving maternal corticosteroids at the first signs of preterm labor, and that facilitates that last-minute lung development to increase the surfactant levels. And then once the baby's actually been born, then we can treat with O2. We can do other respiratory support like intubation if needed. We can also administer artificial surfactant into the airway, and we can give antibiotics until sepsis is ruled out. Other just routine newborn cares that are done for all babies. We do give that vitamin K shot, or we recommend it. In all of medicine, the patient has the right to refuse treatment if they do not want it. And so sometimes some parents would decline vitamin K shots or vaccines, but we do recommend a vitamin K shot. And then we also recommend routine vaccinations like for the hepatitis B virus as well. That's one that we can give in the hospital as early as a couple of days after baby's been born. Madeline is asking, does the baby have to be intubated to administer the artificial surfactant? It's definitely, so you would deliver it through an endotracheal tube. So I would imagine that would make sense that it's either easier to deliver, or if you're going to be intubating them anyways, then you would use that tube. But I don't know if it would be like you have to put an airway tube in just to give them surfactant if they're doing clinically well enough to not be intubated. I don't know if that makes sense, but sorry, 1 second. I'm pretty sure like you would still deliver it through the ET tube, as if that's what you're asking. Sorry, I'm not used to talking this long. Okay, so For a patient update, because I like to do these at the end, our patient is now 2 months old and her corrected gestational age is 38 weeks. So she's still not totally to term, but, is close. She never required intubation or surfactant administration and is breathing well on her own. Within the first week of life, she was treated with a UV light for neonatal jaundice, and that completely resolved. So that was probably just physiologic jaundice, which again is because of the buildup of that bilirubin, the byproduct of red blood cell breakdown. She's feeding well and gaining weight appropriately and is soon going to be discharged from the NICU to go home. Yay. And she'll follow up with both a neonatologist and a general pediatrician for her first year of life to make sure that she's meeting her growth and developmental milestones. So that's pretty common for babies when they're discharged from the NICU, that they see both their neonatologist and their general pediatrician. These are my sources. I normally, if I just use pictures, will put them like underneath the picture on my slide, but I actually did a lot of research for this one to make sure that it was as accurate as possible. So if you're interested in any of these, then please go ahead and take a look. You can find them in the YouTube video when it's posted. Sorry, like I said, don't talk this much very often. So please now, if you are wanting to get that certificate of completion, take some time to fill out that 10-question quiz. If you'd like, I can go back to any of these slides to help you guys with it, or I can put the link to this presentation in the chat for you to use. And I think the Google folder with the additional resources should also be up here in the chat if you need to have like any review of the acronyms or measurements or things like that. And yeah, please also fill out feedback. That really matters to me, and I actually choose my topics based on what you guys suggest. So if you have any requests for future virtual rounds topics, and this should be on YouTube within a week, probably a couple days, but no longer than a week. Are there any other questions that you guys have or anything that you want to go back to? And if not, then thank you so much for joining me. We do record and post these to YouTube, so this one should be up within the week. And if you have any other suggestions, either put it in the feedback or you can email us at MotivateMD. Thank you guys so much for joining. I love doing these and I always think it's super fun, even if my voice like gave out at the end. Feel free to take off whenever you feel like you're ready. And if not, I'll just kind of hang around until people kind of drift away. And I always am also open for any questions about medicine or medical school or applying or anything like that as well. So if there's any non-pediatrics related questions, then you can also ask me those. Yes, Kayla, please ask your question. Okay, so Kayla's asking about signing up for the MCAT. I think that depends on when you feel like you're going to be ready to apply. So for me, I ended up taking a gap year after I graduated from college to do research and to really work on my application development. And so rather than taking my MCAT as a junior, which is like, quote, the traditional time for people to take it, I didn't feel like I was ready to take the MCAT and then to also apply to medical school when I was a junior. So I ended up taking it in the spring of my senior year. And I applied after I graduated from college. So some things that you should consider when getting ready to apply is, how are your grades? Like, is your GPA pretty strong? How is your clinical experience? Do you have like good either clinical volunteering or a history of clinical employment or any sort of patient care experience or shadowing or things like that? That is another really important part of your application. And then once you feel like you have all of that in order, then I think the MCAT is a good like last step to make sure that you've taken care of all these other things. And then last week, someone had asked about taking the MCAT and then applying like after more than a year. And I think we decided that the current guideline is that your score will last for up to 3 years. So say you take the MCAT maybe this summer as a junior before your senior year, but you're not ready to apply right now, then you could take the MCAT still this summer, but then not apply for another year, or even 2 years, and that score would still be good. So that's a great question, but I think it really just depends on what your personal goals are and what your journey has been like. Okay, a couple more questions. Yes, let me pull up the link for this presentation. Here. So that should allow you guys to be able to see this. Ashley was asking, are there any special issues with infant skin besides jaundice? That the skin is very thin. Yes, that is accurate. So jaundice is not anything that really changes the fragility of the skin. It just makes it have like a discoloration. But especially premature infants, they do have very fragile and thin skin. So we try to make sure that when we're doing physical exams and things like that, that we're not applying like too much pressure or friction and using like soft, gentle products to try to avoid irritation. And that when they need to have vascular access, like an IV or a PICC line or something, that we have like really experienced staff try to get that so that they don't have any unnecessary pokes or trauma to the skin. So good question. My major in undergrad for Diana was just general biology. And then I also did a minor in theology. So I attended a Jesuit Catholic university called Loyola Chicago. And so I kind of had both a scientific and a religious educational background. And I loved it. I recommend that people just major in what they are passionate about. And as long as you're taking the prereqs for medical school, then you can really study whatever you want. Or if you wanted to do a science major and do a non-science minor, like kind of what I did, that can also be something to set you apart during your applications as well. For the quiz, what would I write in the subjective section? Yeah, so that would be like all of the case background information, like the mom came in at 31 weeks with signs of labor, her water broke, and she has been pushing for an hour. She had she had gestational diabetes during her pregnancy. And I think that's all like the relevant subjective history. It's just kind of like a description of what was happening, essentially, leading up to it. And then the objective portion would be things like the vitals, the physical exam, the Apgar score, and all of that. I think, is it Katerina? I hope I'm saying your name right. What were the major things that I considered when applying to medical schools? So I am attending my state school. I am a US resident and I'm from Iowa originally. So I knew that my best chance at getting into medical school was going to be at my like in-state university. And so that was for sure one that I wanted to apply to. It also happened to be the most affordable in terms of tuition. Although all medical schools are basically just ridiculously expensive. So I don't think that that should be a limiting factor because almost everyone that I know has to take out loans. I also wanted to be geographically close to my family. I am married and my husband is also from the Midwest. And so we wanted to stay within like basically the bordering states of Iowa. So like Wisconsin, Minnesota, Illinois, Missouri, Nebraska. Those ones are kind of like the main area that I wanted to stay. And they still to this day, even I'm getting ready to apply to residency this year, which is like the first, I've never said that sentence before. So that's really crazy and existential for me. But I'm again going to try to stay in the Midwest and I'm going to try to keep it to places in those states. And then just lastly, looking at the schools and what their values and what their like things that they can provide in your education that you wouldn't get other places. So for example, at Carver College of Medicine, which is where I currently attend, they do things like a condensed preclinical curriculum. So I was only in the classroom setting for 1.5 semester. No, yeah, no, sorry. 3 semesters, 1.5 years. And then we get an extra semester of clinical rotations to explore our clinical interests and try to pick a specialty. So I really liked that aspect of it because then I get more time to do the things that I actually like to do, which is to be in the hospital and work with patients. So yeah, just like do your research and look around at what the schools offer and that what makes them different from others. Destiny said, back to the warmer when babies are born. It's crazy. Sorry, I can't scroll very well. It's crazy seeing just how organized everyone is, even though it looks like chaos. With both of my kids, it was interesting to watch as they all swooped into their part and then cleared out. That's so true because it does feel like there's 20 people in the room sometimes, and then everyone just leaves. But yeah, it's like a very well-oiled machine. And I think that that's one of the great parts about newborn like OBGYN, labor and delivery, and like newborn nursery is you kind of get that collaboration and like the worlds collide a little bit where you have a whole pediatrics team and a whole OBGYN team and all of that. And again, everyone just kind of does what they're supposed to and the results work out really well. Another question, still in high school. Oh my gosh, I did not know that you were in high school. You're amazing for being here. I feel like I didn't know what was going on in high school and I want to be prepared for applications next year. Could you tell me what my interviews were like? So I guess I'm not sure if you're applying to medical school next year. If you're in the US, then like you would attend a 4-year university, or I guess there's some combined BS MD programs that are out there. So for my college, I didn't have to interview. I just did an application and was accepted without interviewing. But for medical school interviews, which was after I had graduated college, I looked up kind of what the school's past interviewees had said were common questions and tried to prepare for those questions. So things like ethical circumstances, things like why I wanted to attend this school specifically. So to do some research on what makes this program unique compared to others. And just kind of the basic, like when they ask, tell me about yourself or what are some experiences that you've had that would make you a good applicant. Just kind of standard interview prep, I would say. Good interview etiquette, like writing thank you notes and having questions that you can ask your interviewers when you have the opportunity to do that. So hopefully that answers your question. If you have any more questions about the timeline for applying to medical school, then there's really great information, I think, out on Motivate MD website, or you can always email support at Motivate MD, which I think is still on my screen right now. And we can connect you with someone to help get your questions answered. What other questions do you guys have? I think we're down to just the three of us. If you have more questions about applying to medical school or anything in medicine, I'm happy to do so. Or we can go back to anything in the case as well. It is 9/11. I don't have anywhere to be, and I love talking about this, so I could sit here for as long as you guys need, but if there's anywhere that you have to go, then please feel free to take off at any time. Yeah, thank you so much for joining. I hope that this was a good experience for you. I feel like this was, for me at least, the case was a little bit last minute, and again, like I said, my voice started to give out at the end. But yeah, we have new topics every week, and it's always a great thing to get new people to come join us. So thank you for joining us tonight and for asking questions and participating. I think that it's really awesome that you were here. Do you know what the timeline for applying to med school looks like for a non-traditional student? So I guess that would be really dependent on what the person. So for you, you graduated college, did 4 years in your field, realized it wasn't what you wanted, so now you're here. Okay. So I think it depends on like what your field was. If it was something in science, like biology, for example, where you've already taken the prerequisites, that would be, I think, be your first step. Is you'd have to go back to complete any classes that haven't already been part of your college journey. So those vary by school, but they're essentially all going to be like a general biology, general chemistry, organic chemistry, physics, and some other more sciencey classes. So completing those and trying to get as good of grades as possible in those classes would be, I think, probably a good starting point. And then alongside or after that would be building clinical experience. So it looks like as a special education teacher, I don't know if you like had ever worked in a clinic or hospital setting or volunteered with any of those types of patients. But I know the admissions committee love non-traditional applicants and the life experiences that they have and can bring value to their entering class. So I think that that's actually a great strength that you have, and would just have to build on that with some more medicine specific activities and classes. So like it depends on, I guess, what if your interests are within like still pediatrics and maybe like volunteering in a peds clinic, or sometimes even at hospitals, if they have a NICU, you can hold the babies and help provide them with like that tactile stimulation. Working as a scribe, working towards CNA. Yeah, so that's perfect. I think that scribing is great because you're working directly with the physicians and learning a lot of the terminology. And then CNA is always, I think, a great skill to have because you just, can do so much for the patients, not just before med school, but there's things even now as a student that I wish that if I had had more of a hands-on patient care role, then I would have been able to like do more just like helpful tasks in the hospital. So I think, yeah, that would be a perfect thing. And just to look into, if you haven't already, acquiring those prerequisite classes and trying to keep your GPA as high as possible would be a great starting point. So I think it's amazing that you are realizing what your life path is supposed to be and have the courage to make that change, because I know a lot of people would struggle with that. And you're right. Yeah, the MCAT is definitely challenging even for people who studied sciences in college. But at the end of the day, those same prerequisite classes that I mentioned before, like the general biology, general chemistry, organic, and physics and things like that, are the same ones that would be tested on the MCAT. So having less of a scientific background would not necessarily put you at like a disadvantage for that, because in order to even apply to medical school, this is the same stuff that's on that test. So, and it is a lot, and it's usually about 3 months of just your life is really hard and kind of sucks, but you, like everything else in life, you just get through it. And also remind yourself to take one thing at a time, that if it's not like directly in your future, to not waste the mental energy worrying about it, if you can have that discipline. I know it's hard, but try to focus on the things that are in front of you now and just take it one step at a time and work the plan.